Welcome to our webinar titled Treating Aplastic Anemia in Older Adults. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the program today. It is possible during the program you may lose your connection. It is possible if you happen to lose your connection during the program, you can call in to hear the audio portion using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window. We'll do our best to get to everyone's questions today. When asking questions, I do ask that you do 2 things to help us manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Our specialist today is Bavisha Patel. Dr. Patel is a staff clinician at the National Institutes of Health, where she works on the hematopoiesis and bone marrow failure team. Dr. Patel and the team provide clinical trials on aplastic anemia and other bone marrow failure syndromes, helping to advance research and finding a cure. Thanks so much, Dr. Patel, for joining us today. We're so glad you're here with us.
Thank you. Okay, I'll go ahead and share my slides and start. So I've prepared a talk for about 45 minutes, and then we can open it up for questions. And the topic I would like to cover today is treating aplastic anemia in older adults. And before I begin and go into my talk, I want to say that NIH, we see probably more adults than children, because children are generally referred to for bone marrow transplantation as their primary therapy. So while this is a disease of children and young adults more commonly, at NIH, it feels like aplastic anemia is much more common in older adults. So hopefully I'll share some evidence-based data and also some practical issues that we run into when we are treating older adults. So with that, the objectives of my talk is I will review the pathophysiology of severe aplastic anemia. Then we'll dive right into the first-line treatments that are offered in older adults and what happens when the disease is either refractory or after initial response, the patient has a relapse of the disease and other long-term complications that we encounter. So many of you probably are already aware that aplastic anemia is much more common in Eastern countries than it is in Western countries. We don't completely understand why is the case. And actually, we have a study ongoing that looks into genomics to see if there is the answer there. Although aplastic anemia is classified as benign disease, patients get very ill from having low blood counts and having complications associated with it. The diagnosis is not very difficult, but there are other diseases that mimic aplastic anemia. So it is important that we make the right diagnosis, but essentially we look for low blood counts and an empty bone marrow. As I mentioned earlier, the age distribution is there's sort of a bimodal peak from 10 to 25 years of age, and then again at more than 60 years of age. And my talk is pretty comprehensive, but I'll focus on the more than 60 years of age or more than 40 to 60 years of age patients. Severe aplastic anemia used to be universally fatal in 1900s, but now it's treatable in most patients, whether it requires one immunosuppressive round or two. Most of the patients, we can get them into remission. So there are many different causes of aplastic anemia as a pathophysiologic diagnosis, but the most common is immune destruction, acquired or idiopathic. There are some causes that are related to this, but majority of the time we don't know what incites the immune system to cause destruction of the bone marrow. But when we look at the bone marrow biopsy, all of these different causes, they present similarly, which is that the marrow is empty and there is not production of the blood cells as it normally should be. And as the differences in the etiology are, the treatments are also different. And for our purposes today, we'll focus on the immunosuppressive therapy because this is the mainstay of therapy for older adults. Other treatments that are available, and one that I'll go back and forth to, and why it is not ideal for an older patient to get stem cell transplantation is a stem cell transplant. So just to kind of give you an overview, our bone marrow cells are broadly divided into lymphoid and myeloid. And in the periphery, so in your blood, we have many different types of lymphoid cells, and we have many different types of myeloid cells. So myeloid cells that some of our patients very familiar with are neutrophils, platelets, and your red blood cells, which is what your hemoglobin is based off of. So what happens in aplastic anemia? In aplastic anemia, it's your T lymphocytes, so a subset of lymphocyte population that actually does not listen to any signals of self-destruction and ends up destroying your myeloid cells, resulting in low neutrophil count, low platelet counts, and low hemoglobin. Not all patients have all three lines to be low, but generally for severe aplastic anemia, we see that to some degree, all of these three lines are affected. As I mentioned, when we look at a bone marrow, there should be a lot of blue and red going on over here, but pretty much what we see is that empty. We don't see many cells. Instead, we see that everything is replaced by fat or adipose cells, as you could see here, these clear white ones. We do see some cells. They're mostly lymphocytes and plasma cells. And one very, very important thing that we pay attention to and we make sure our pathologists pay attention to is whether there is any dysplasia in the cells that they do see. So what is dysplasia? Dysplasia is basically a cell that does not look normal. And why is that important? Because one of the differential diagnoses of aplastic anemia is myelodysplastic syndrome. And myelodysplastic syndrome is a malignant or cancerous process and is treated much differently. And this distinction or overlap is much more common in older adults. So we really, really go over and review the bone marrows of older adults very carefully to make sure that we don't see any evidence of dysplasia that would be suggestive of an alternative diagnosis. So what are the differential diagnoses we consider? So in children and young adults, it's different compared to older. So in children and young adults, we want to make sure that they don't have an inherited cause of marrow failure. And this we accomplish by checking their telomere length, checking a specialized test for Fanconi anemia, and more commonly now, because especially at the NIH, we just perform a genomic panel to look for all the genes that we know could be mutated in bone marrow failure. And if that in the absence of these genes being mutated, we know that the disease is acquired. So what about older adults? So older adults, as I said, myelodysplastic syndrome is really the one differential that we want to make sure is ruled out. In the bone marrow, I told you that we look for dysplasia. Every bone marrow biopsy that is performed, cytogenetics are sent, and this is basically you have 23 chromosomes in pair. We want to make sure that there are no abnormalities of those 23 chromosomes. Sometimes a part of the chromosome can be missing, sometimes an entire chromosome can be missing, sometimes there are two chromosomes that are joined together. So we look for these abnormalities. And then more recently, now genomics is, utilized in pretty much all the diseases in hematology. We also know of some bad mutations that could be present in aplastic anemia that may be indicative of something else going on or something to pay attention to. So what are what does it look like, and what do I mean when I say mutations? So there are basically a panel of mutations that we look for in what's considered myeloid disease, which aplastic anemia is. And in aplastic anemia, we see very different mutational profile, meaning the genes that we see that are mutated are very different. So the common ones are B-core, PIG-A, DNMT3A, and something called 6P-LOH. Basically means that there is a loss of a copy of 6th chromosome. And all of these together are indicative in aplastic anemia of immune pathogenesis. So patients, and I've not included in my presentation today, when we looked at patients who had a PIG-A mutation and the ones who did not have a PIG-A mutation, we found that having these mutations actually shows that they are going to respond to immunosuppressive therapy, again, indicating that this is truly an immune disease. Now, what if we start seeing some of the mutations that we commonly see in myelodysplastic syndrome? So some of the ones I've listed over here in red, so RUNX1, TP53, splicing mutations, these are genes typically associated with a more malignant disease. And when we see them, when they occur in a pretty high fraction, we are cautious and may sometimes even repeat a bone marrow biopsy before proceeding with the therapy of aplastic anemia, because we want to be sure we have the diagnosis correct. And this is very much more important in older individuals because myelodysplastic syndrome is much more common than aplastic anemia in older individuals. Let's get back to the clinical presentation. So once we have made a diagnosis of aplastic anemia, what are some of the things that a complication of untreated disease? So patients with neutropenia have high risk of infection. This risk of infection really increases when the neutrophil counts are less than 200. Or less than 0.02, some of the reports reported that way. For thrombocytopenia, the risk of bleeding really does not increase till less than 10. And when I say risk of bleeding, I mean spontaneous bleeding without hitting your hand or without having any trauma. So platelet transfusions are generally reserved for those patients. And why is that the case? This is the case because we don't want our patients to become platelet transfusion resistant. This is something that we observe even when we transfuse at less than 10, but we want to reduce the risk as much as possible. And then anemia typically presents as tiredness, shortness of breath. And for the blood transfusion, we generally reserve it for less than 7, but in some of our older individuals, this threshold is changed. So what are specific challenges or issues with older adults? So neutropenia, the infection pattern with neutropenia is a little different in our older adults. We see that the infections that are common also present more commonly when patients are neutropenic. So pneumonia is very common, urinary tract infection is very common. And our older patients are more prone to getting very sick and getting something called sepsis, which basically means that the infection is so out of control that it starts affecting their blood pressure and really affecting their organs. And patients can really get very sick and require ICU care. For anemia, in our younger folks, we see, nosebleeds, mouth bleed. In our older, and I'm talking about, now much older, probably 60s, 70s, we start seeing that, GI bleed. So bleeding from the rectum when they have a bowel movement, or that with the anemia patients having chest pain. And then this is not, I feel a little bit of tightness. I'm having true chest pain. And this is basically, if there is an artery that is blocked, it really is unmasked by the degree of anemia, because when the hemoglobin was nice and robust, the oxygen was still being supplied to the blocked artery. But when the hemoglobin is lower, it no longer is able to keep up with the oxygen that the heart needs to function. Dizziness is common and associated fall. So sometimes for my older individuals, older patients who come in with anemia and who give me this history of chest pain or have cardiac history in the past, we recommend that the hemoglobin goal is higher at more than 8 rather than more than 7. And for thrombocytopenia, again, our goal sometimes can be higher for older individuals if they are already on blood thinning medications that we cannot stop. For example, a patient who has just had a cardiac event and a stent was placed and they're on Plavix. If they had this 2 years ago, there's no problem. We can stop the Plavix. This will not be an issue. But if they just had it within a month or 2 months, we work closely with the cardiologist to be able to give that medication, but also transfuse the platelets at much higher goal. So what is the general approach to aplastic anemia treatment? So as I mentioned, 2 broad categories is immunosuppressive therapy and allogeneic bone marrow transplant. In our children and also in our young adults, we always look for allogeneic bone marrow transplantation as an option before we go to immunosuppressive therapy. In our adults, older adults, so for aplastic anemia that's older than 40 years of age, and I'll show you the data as to why we use 40 as a cutoff. The treatment approach is generally immunosuppressive therapy first, and then we can get to bone marrow transplantation, depending on the comorbidities. And that decision is really individualized, depending on the patient and other medical conditions that they have. So bone marrow transplantation is very, very attractive, right? It is the only curative option for aplastic anemia patients. It eliminates the risk of clonal evolution, one of the issues that exists with immunosuppressive treated patients. But there are big concerns. There are issues with mortality that is associated with bone marrow transplant as a procedure. There is a condition called graft versus host disease, and the graft can fail, and you can have the aplastic anemia again. So it's pros and cons that need to be discussed and individualized to the patient. Here, I just wanted to, this table is really busy, but what I want to show is that in children and young adults, the survival outcomes, survival is what we look at. That's sort of the major benchmark. We want to make sure that we're able to give patients quality of life and also quantity of life. So in children and young adults, transplant does very, very good. This is not really translated in our older adults. And here is one of the very old study, very nicely performed study in over 1,000 patients. And they basically looked at 5-year overall survival and divided by age. So the categories that they included was 20 years, 20 to 40, or less than 20 years, 20 to 40 years, and over 40 years. And as you could see, the curves are much lower for the patients who are more than 40 years when they went to bone marrow transplant. So that is why 40 years of age is our cutoff to kind of determine whether bone marrow transplant is a first-line therapy versus versus immunosuppressive therapy. And this was recently looked at again because there are advancements in both of these treatment modalities, immunosuppressive therapy and bone marrow transplant. So have we made a difference? So there was a recent study that was published in 2018 that looked at, okay, let's look at patients who are older than 40 years of age, divide them into whether they received transplant before 2009 and after 2010, and see if there is a difference. And as you could see, the curves really overlap. I didn't put in the curve for younger adults, and it really separates. So we know that, the the complications and the issues that result in poor survival for patients who are older than 40 are still not something that have been overcome in transplantation. First line, I'm talking about first line. We'll get to when and if transplant needs to be considered in older adults later on. So what is the big issue? The big issue really is this graft versus host disease. It is a feared complication of bone marrow transplant. It comes in two forms, acute and chronic. And what is it? It's basically when the donated stem cells view the recipient's body, so the person who's getting transplanted, their body as foreign, and mount an attack. So the patients can have liver failure because the immune system attacked the liver. They can have rashes, they can have dry eyes. It can really be any organ. There has been improvement. Graft versus host disease was much bigger problem than it is at now. And there are better immunosuppressive prophylaxis, and it is much improved. And now, even when you get it, when a patient gets it, there are better alternative agents other than just steroids to treat it. So there have been advancement, but it still remains the major problem in bone marrow transplant. And this is again to show that, in every study after study, age is always shown to be one of the predictors of how patients do after bone marrow transplant. So I'm going to pivot and talk about immunosuppressive therapy, because this is really the first line treatment that we offer, and all major institutions would offer when they see a severe aplastic anemia patient that's older than 40 years of age, certainly when they're older than 60 years of age. And the therapy is considered triple therapy, triple regimen. It's horse ATG, cyclosporin, and L-trombopag. And here I've put in a little diagram to kind of show you that cyclosporin works on activated lymphocytes. Remember the T lymphocytes that are problematic? The horse ATG also works on lymphocyte. Basically, horse ATG just knocks them down. The lymphocyte counts are non-existent after horse ATG. And cyclosporin's goal is to prevent from the activated T cells from coming back. And on the other hand, at the same time, we use a TPO agonist or L-trombopag to stimulate those hematopoietic stem cells in order to make those platelets and make those hemoglobin in the periphery. The regimen that we had used over here, and now it's standard, is that you continue the L-trombopag and cyclosporin for 6 months, and then you go on a low dose cyclosporin to make sure those activated T cells don't come up. And within this maintenance phase, patients can still have a relapse. And if that occurs, we increase the cyclosporin dose again. So what is horse ATG? So what are specific considerations? So I wanted to kind of go over the side effects and what practical considerations I have as a physician who's treating a aplastic anemia patient with these medications. So horse ATG, as you may know, is something that's given through intravenously, and it's given in the hospital, and typically it's for 4 days and it's 4 consecutive days. In some patients, we have to give it slower, which is okay. And this therapy is really high risk for older adults, and especially older adults with comorbidities, patients who have cardiac issues or pulmonary issues. And why is that the case? Horse ATG can result in fluid shifts. If the fluid shifts outside of the blood system, patients can have effects of their kidneys. If the fluid shifts too quickly inside, patients can have fluid overload, and the lungs get filled with fluid, and we have to manage that. Horse ATG also predisposes patients for heart rhythm abnormalities, and this is particularly more common if a patient already has cardiac history. So what we do is, for these patients, because they are high risk, we want to make sure that we provide best supportive care. We sometimes start the horse ATG in the ICU. The first 2 days of horse ATG are probably the most problematic, and the last 2 days are, the issues are much less. There could be allergic reactions, and also there could be liver toxicities. all these issues are something that we know. So what we work for is never decline a patient for ATG just based on their age, but that we want to make sure that we are prepared to handle any complications that may arise. There are, very frail. I'll give you an example of, say an 87-year-old patient who is very limited in mobility, who gets aplastic anemia. Now that patient may be much, much higher risk of complications. And in that patient, sometimes what I do is I start the L-Trombopag and cyclosporin alone to see if there is a response. We actually have a study that came out of Brazil that showed that there is about 50 to 60% of the patients who may have a response with just L-Trombopag and cyclosporin. The response is not as robust, but it gets you out of trouble. It can get you transfusion independent, can get the neutrophil counts high enough where the patients are no longer required or not at high risk of infection. Cyclosporin, there are short-term and long-term toxicities. In short-term, it can affect the kidneys, but generally this is reversible and something we can handle with dose changes. Same thing with blood pressure. There are patients who may end up on blood pressure medication, but again, when we decrease the dose of cyclosporin, most of the time we're able to get those patients off of the blood pressure medication. Long-term toxicities is something we worry about more, and that's why our goal always, even in the setting of relapse, to use cyclosporin for the shortest duration possible and start tapering as soon as we can, because there is this chronic kidney disease that can occur in some patients who are on cyclosporin for years and years. And then there is this risk of skin cancer. Again, when the patients are on cyclosporin for years and years, we make sure that they have good dermatologic follow-up. Not everyone who's going to be on cyclosporin will get skin cancer, but the risk is certainly higher. Now, Trombopag is probably the best tolerated drug in all age ranges. We see elevated liver function test in patients as the most common side effect, but this is no different than what we would see in children and young adults. There is this risk of or concern that if someone takes L-Trombopag for a long period of time, can it promote myelodysplastic syndrome because we're stimulating those stem cells? And the robust data is not there yet because, L-Trombopag has only been around since it has been FDA approved in 2017, so we don't have long-term data. But patients with other conditions who have used L-Trombopag, this does not seem to be the case. So at the moment, I don't think there is increased risk, but to really definitively say that, I would need data, which I think are going to come in the next 4 to 5 years. So I told you that about 80% of the patients may respond, and the response rate is higher in older adults than it is for children with immunosuppression therapy, plus L-Trombopag. So what happens to the 20%? What do we do in those patients? So 10 to 20% don't respond. There are many different causes of why they may not respond. Can they have some other etiology other than severe aplastic anemia? So we always do another bone marrow biopsy before we move to a second-line treatment. It is possible that by the time the patient arrived to receive treatment, that most of their hematopoietic stem cells were destroyed. So there was nothing to stimulate. There was nothing to come back. And in that situation, even a second round of suppression is not going to be sufficient, and this patient will most likely require a bone marrow transplant. So there are situations where we don't have any other option other than bone marrow transplant. So can we predict who may have a response to immunosuppressive therapy? And we can. We look at two different blood values, absolute neutrophil count and absolute reticulocyte count. And both together are predictive they give you a percentage of what are the likelihood that this patient is going to respond. So when the absolute reticulocyte count is over 20, and absolute neutrophil count is over 300, roughly, we know that this patient has a very good chance of responding. And on the other hand, when they're both low, the chances are close to 50%. So what in an adult, if an older adult that I treated with horse ATG, cyclosporin, or Tromopeg does not respond, what do I recommend? Generally, in most patients, we would recommend to receive a second course of immunosuppressive therapy. And that could be either rabbit ATG. We don't use horse ATG again here in America, or Campath or alemtuzumab. And we have shown in our studies that both rabbit ATG and Campath are equally efficacious. Why not transplant? With transplant, I think if I have a 60-year-old who's extremely fit and behaves more, like a 40-year-old, what I typically do is refer them to a transplant center, get their transplant evaluation started. Once you send someone for a transplant referral, to knowing whether or not they can get transplanted, it can take a month or two. And I would not want to leave that patient untreated. So meanwhile, the patient can start getting second line of immunosuppression, have their transplant evaluation already underway, and then that way, if they did not respond to the second line of immunosuppression, transplant is an option. They can move ahead and go with the transplant. Here are the rates of rabbit ATG and Campath. Because this is a second line therapy, you see the percentages or the response rates are not as good as the first line. So it's about 30 to 40%. And how do we choose between the two? Personally, our NIH, we favor Campath because you don't have to use cyclosporin along with it. And many patients have toxicities with that. And Campath is similar to horse ATG in many ways as far as side effects go. So this is generally also administered in the hospital. What is one thing that's different about Campath is that it's a very good immunosuppressive drug. So it does its job very nicely, but patients may be left with low lymphocyte count or prolonged immunosuppression for a long period of time, which puts them at higher risk of infections for which they may need to be on prophylaxis like acyclovir for longer than they have to be with horse ATG. Supportive care is even more important in patients who have refractory disease because they, by the time that they're refractory to first-line treatment, they've already been transfusion dependent for about 6 months, and they may be for another 3 to 6 months. So I've listed all the typical recommendations that we have for transfusions, which is not very different. And then I've also included over here the need for prolonged antiviral prophylaxis with Campath. So let's briefly touch on what happens when a patient has a great response or a response where they became transfusion independent and had their improvement in their neutrophil counts slowly starts declining their blood counts. So the issue of relapse is actually a difficult one because patients may have destabilization of their blood counts depending on what else that may be going on. So sometimes our patients who have viral infection, they may have platelet counts drop from 90 to 60, but then stay at 60 and then slowly come up. So what we look for is that trend. So oftentimes I tell my patients, let's check it every week and, we'll see where your blood counts go. Either they will stabilize or they will continue dropping. There are two variable presentations. One, there would be abrupt drop of all 3 blood counts. And when that's the case, it's pretty clear cut. Not many things cause that. But when there is a slow decline in one of the blood counts, that is the one that I follow rather than having a knee-jerk response and starting treatment. We have shown, and other groups have shown as well, that unfortunately, similar to bone marrow transplant, in our patients who are older, they do have higher risk of relapse. So the curves are now sort of opposite. They're going up because this is risk of relapse. So the patients who are less than 40 years of age, their risk of relapse is about 30%. At the 3 years, but this continues to go up for patients who are more than 60 years of age. This is a little bit misleading. It says 80% over 50. 60. That's not true. It's just cumulative incidence, and that's why it's high. I think for older patients, I worry a little bit more and watch them or do blood work check much more frequently than I do for my younger patients. So what do we do if and when a patient does relapse? So if a patient has abrupt drop in all their blood counts where they became as severe as they initially presented, I just very quickly in our older adults go to second round of immunosuppression. So either Campath or rapid ATG. But they have a very slow decline where relapse is not causing such low blood counts where the patient's transfusion dependent. What we do is we initiate just one drug, cyclosporin, at the higher dose as we typically do, and assess response in 3 months. And if it still doesn't respond or if the counts drop further, I add altrombopag. This is just in an attempt to rescue and restabilize the immune system by using the oral drugs. And if that doesn't work, then in our older adults, we go to second line of immunosuppression. Again, as I mentioned, in a fit older adult, we never want to decline bone marrow transplant. So we start the bone marrow transplant evaluation at the same time to see if it's a realistic option. And if it is, we can get to it as a third line option. And here I'm showing that about 70% of the patients who receive cyclosporin alone or cyclosporin in combination with altrombopag, so just oral therapy, were able to rescue about 70% and not have the requirement for receiving second line of immunosuppression with Campath, rapid ATG, or needing bone marrow transplant. The response rates with rapid ATG and Campath in the relapse setting is double. So it's about 50 to 60% compared to 30 to 40% when it's used in refractory setting. And as I mentioned before, the decision between which one to use is really the physician comfort and experience with managing the complications and the tolerability of the cyclosporin. Campath does not require cyclosporin. Rapid ATG, you have to take cyclosporin for another 6 months to 1 year. So those decisions are individualized based on the patient and the physician preference, and whether there are any other toxicities left over from first-line usage of cyclosporin. So bone marrow transplantation for my children and young adults, after they fail the first line, I want them to go to bone marrow transplant if that's an option. For our adults, because of the survival being so different, we don't go to bone marrow transplant as a second line. Although in some of our patients who, fit patient is one, but second one is also when they have really, really low blood counts and they have available matched sibling donor. So the donors also become very important. So it's a complicated decision, and that's why we always refer our patients to a transplant center, so that decision can be made together by a doctor who gives immunosuppressive therapy and someone who can do bone marrow transplant. Let's talk about evolution to malignant disease. A very small fraction of patients with aplastic anemia who get treated with immunosuppression can have their disease evolve into myelodysplastic syndrome or leukemia. About half of these are worrisome and require prompt treatment, and the preference here would be bone marrow transplant. Now we're talking our risk versus benefit is very different, right? Because you are trying to treat a malignant disease where other options are not as good. So you are willing to take a little bit more risk in terms of toxicities. So you have to weigh that. When we look for who are the patients who are at higher risk for having this evolution, we again found that older age and patients who have received multiple lines of treatment and have not responded are the ones who are at higher risk. And this is because we accumulate mutations as we get older. So you the chances of already having a bad mutation that can potentially evolve under stress is much higher. And same thing happens when, your bone marrow is under stress trying to produce when your disease does not respond. It's the same thing. The chances of having a bad mutation or bad abnormality is just much higher. And this is what I'm showing over here. So that's all I have. So in summary, what I went over are the considerations we have in choosing the first line treatment for our older individuals. What are some things I keep in mind with the drugs that I use for the treatment of our older individuals? And then if they do not respond to treatment, what are our general recommendations? If they do respond to treatment and relapse, what are our recommendations? If they have evolution of disease, generally the preference is bone marrow transplant. If this is an option, meaning if there is a donor that is available and the patient is fit enough to go through a transplant. And this is a very, very detailed evaluation that any transplant center does. And lastly, I wanted to end with all the ongoing marrow failure protocols we have at the NIH. So we're continuously working hard to make our immunosuppressive therapies better. The most recent protocol that we have is an exciting one that is currently running, which is that we start the oral therapy, so cyclosporin and L-Trombopag, as soon as we have a preliminary diagnosis of aplastic anemia, in an effort to stop that immune attack as soon as we can. And then we would schedule the patient to administer a course ATG. We also have a relapse prevention trial where we use a slightly different drug than cyclosporin. It's called sirolimus. And this is, again, an attempt to reduce the necessity of a cyclosporin for a longer duration because of the toxicities that are there for with the use of cyclosporin for a long time. And then telomere disease, I just added this. We also study inherited disease, and we do have a protocol open. Most recently, we have just opened a natural history protocol, and this is for patients who have been treated with aplastic anemia at our center, and now we are following them to learn, what happens to these patients, what is their quality of life, are there any other issues that come about, even if their aplastic anemia is no longer a problem, so we can follow our patients lifelong. So that is something that we're doing on our natural history protocol. And we are always, always thankful, and we would not be able to do any of this work without our patients and research participants. Our leader, Dr. Neil Young, who started this program, and now he has many, many people like me working with him, under him, alongside him, to provide the best care that we can to aplastic anemia patients. And here is all of us, plus me. I still have to update this picture since the pandemic. So I went on my maternity when this picture was taken. And since then, we have not gotten a chance to take another picture because we're still sort of on partially remote schedule. Some people come in, like I like to come in the office all the time. Some people don't. So hopefully this year we'll update, but this is our team. Thank you so much for all your attention, and I'm happy to take any questions you have.
Thank you so much, Dr. Patel, for the wonderful presentations. And we equally have some great questions for you to answer. Our first question is, after ATG, if platelets are going up, but ANC and hemoglobin are staying the same, is this considered is that normal?
Yes. So we can see varying degree of responses in patients. So our goal would be that we can get you transfusion independent. So if the platelets are going up very nicely and your hemoglobin has gone up to a point where you are no longer transfusion dependent, but it's not normal. So say, your hemoglobin is now at 8 or 9, and your neutrophil counts are above 500, but are still lower than normal, we would still consider that a response.
Thank you. Our next question is, after ATG treatment, what is the time that it normally takes for the hemoglobin, ANC, white blood count, and platelets to start to increase? And if on cyclosporine and Promacta, what is the drug that will help the hemoglobin and ANC?
Okay, so I answer the first question first. It differs from patient to patient. Generally, what I find is that platelets are the last one to go up, although that's not always the case. We have many patients who have complete recovery of hemoglobin ANC, but platelets are trailing behind. These three lineages don't have to behave similarly. And there may be a lag in one or the other. But as I mentioned, our goal really is, get you transfusion independent first. If you meet that goal, then we just continue following, you continue taking the treatment. And remind me what the second question was, something about being on cyclosporine and Trombopag.
Sure. It was, if on cyclosporine and Promacta, what is the drug that will help the hemoglobin and the ANC?
That would be the treatment. So if we think that the cyclosporine Trombopag has not done its job, generally by 4 to 6 months, then we would actually recommend second round of immunosuppression, which would be either Campath or Revit ATG.
Thank you. And this question is in regards to relapse. When do you typically see a relapse? And if no relapse initially, how many years does it typically take that you would see someone relapse over 65?
Yeah, very, very good question. Majority of our relapses actually occur earlier on. So I would say of the 40% relapse rate, about 2/3 would occur between 6 months and 1 year. And the other 1/3 occur between 2 years and 3 years. So for my patients who have not relapsed, by the time they are 4 years, 5 years, the risk is very, very low.
Thank you. If a patient is weaning off cyclosporine, how long do you keep them on a cyclophore, and atovaquone?
Generally, when they are on low dose cyclosporin, where we're no longer checking their levels, and their lymphocyte count is more than 500, we can take them off both of those prophylaxis.
How long is it recommended for an aplastic anemia patients to be treated with Promacta if it has been a successful method of treatment?
Yeah, so Promacta, we handle it similar to cyclosporin, which is if it's used in a relapse setting, and I have achieved a very stable blood counts, I'm happy with it, I start titrating the patient down. So we would go from 150 to 125 to 100. And we would watch the blood counts. If there is ever destabilization, meaning I start seeing that the blood counts drop with my last decrease, I stay at that dose. And the goal here is that we would ultimately wean the patient off, but it's a slow wean, similar to cyclosporin.
Okay. And you may have already answered this question, but over what period of time is cyclosporine weaned? And in what increments? Is this based upon a trough level or just 20% less of the dosage in the AM or PM?
No, so we typically go down by either 25 milligrams or 50 milligrams, depending on the blood counts that we're starting with. And generally, our approach is a very slow wean. So every month or two, we go down by 50 milligrams. So that would be 25 in the morning, 25 in the evening. And at the same time, we would be checking the blood counts. So very similar to Trombopag that I just answered. If I see that there is any destabilization, I would stop at that drug and give it a couple more months before going down further.
Thank you. Give me 1 minute.
Sure.
had some questions that came in by email and I just want to get to those. Okay, thank you. What is the response rate for patients over 65 who are taking only cyclosporine and Promacta, and have had no ATG?
Oh gosh, very good question. So that's the SOAR trial. I think the response rate is somewhere around 50%.
Okay. Are there any specific statistics for response rate to treatment for older adults with severe aplastic anemia that are not mixed with the younger patients?
Yes, so we have done that analysis, and in fact, patients who are, so the response rate over 40 years, over 40 years sort of gets compiled together. So the data that I know of is over 40 years and over 60 years, and the response to initial therapy, it's actually very good. It's upwards of 80%. Keep in mind that we also look at other factors, right? So what is your starting neutrophil count? If it's very low, the response rate decreases, and also your absolute reticulocyte count, which is a marker of baby red cells, which also impacts the response. So everything gets taken in together.
Is it always necessary to put patients on prophylactic antibiotics? This patient was put on Levaquin with worsening neuropathy. Cipro does the same. The white blood counts with differential low, but they've had no infections.
We actually at the NIH do not do antibiotic prophylaxis at all.
Okay, thank you for that. What is your recommendation for COVID vaccine and flu vaccine for older aplastic anemia patients?
This is a very good question. And historically, because of the fear of a theoretical relapse when you receive vaccination, we were telling our patients not to get flu vaccine and just use other measures of being safe. But with the COVID-19 vaccine being so widespread and a disease that was affecting older individuals as well, we recommended our patients to get COVID vaccine, weighing risk and benefit. And we were able to aggregate that data, and we actually published on this. And what we found is after the vaccination, there may be some decline in the blood counts, but this is not permanent. Most of our patients have stability of their blood counts after the vaccine, except for the patients who already had declining blood counts at the time of getting the vaccine. So relapses from vaccination were rare. So, for now, we are recommending our patients to get COVID-19 vaccine, and flu vaccines we're recommending if they have stable blood counts and they are, not within the first 6 months of their treatment.
Is Campath a new drug, and when is it used in treatment?
Campath is not a new drug. We actually studied and published a while back. I'm trying to remember the year. I want to say 2012. It is also called alemtuzumab, and it's generally reserved for second-line therapy if a patient has refractory or relapse disease. It's actually a drug that is very well known in the multiple sclerosis community because it's one of the first agents that they use. Unfortunately, the company was not interested in developing this drug further in aplastic anemia, so we were unable to do any further trials to bring it up front. It would be an ideal regimen for us to do Campath and eltrombopag, but we were not able to. So generally, we reserve this therapy for refractory and relapse. And indeed, the company has made this drug available for compassionate use free of charge for all of our aplastic anemia patients.
Thank you. Can you explain platelet resistance? How much is too much for transfusion-dependent patients?
There is no clear-cut number of platelets where you may become platelet resistant. In fact, there are some patients who may actually develop alloimmunization after 1 unit of platelet transfusions. And there are other patients who may receive many, 50, 100 platelet transfusions and never develop alloimmunization. But we do know the more the transfusions, the more exposure that you get of different antigens. So likelihood is higher. Unfortunately, I don't have a strict cutoff.
Would you ever consider increasing eltrombopag rather than cyclosporine if there is a remission, if the patient has significant negative side effects of severe tremors and gum swelling?
Yes, yes. So in some patients who have toxicity to cyclosporin or have not tolerated it well, and we thought that oral therapy is something that may help them, we can only use eltrombopag. There is data, and we have done that.
Is it possible to use tacrolimus over cyclosporine if a patient has negative side effects to the cyclosporine?
Absolutely. Yep.
What is considered a low dose of cyclosporine? Patient is receiving 50 ml suspension, not pill form. Dosage is currently 2 ml and will begin to wean.
So I will try to do the math. So generally low dose is once a day, and it's weight based. What we consider low dose is 2 milligrams per kilogram.
Okay. Thank you for that. And this question is actually about the telomere study you mentioned. Can you restate what the telomere study is about, and how does someone find out who is a candidate for the study?
Yeah, so telomere study is for telomere disease patients. So these patients have been identified to have bone marrow failure due to having low telomere length from an inherited mutation. So if you are someone who has low telomere length and have known family history of multiple family members either having aplastic anemia or other blood disorders, have early graying, have liver issues that have been really not tied to any particular cause. These are the patients we worry about telomere disease, and then we diagnose them. And if there's a diagnosis of telomere disease, we are studying danazol as a treatment for it.
Thank you. Can Campath be used for a patient who has kidney issues? And if not, are there other treatments that could be used for an aplastic anemia patient who suffers from kidney issues?
Yes, so depending on what line we are talking about, for the frontline setting, when patients have kidney issues and we cannot use cyclosporin, we sometimes substitute tacrolimus. So it'd be horse ATG, tacrolimus, and eltrombopag. For the second line setting, Campath, absolutely. It can be used in patients who have kidney issues.
Well, thank you so much, Dr. Patel, for sharing your time and your expertise with all of us today. If you'd like to watch this webinar again at a later time, it will be available on our website within just a few business days. If you have any additional questions, please send them to us at help@aamds.org. Give us a call at 800-747-2820, or you can submit your question to our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, we'd like to thank you for joining us and making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our program. Thank you again, Dr. Patel.
Thank you so much.
Happy holidays.
Happy holidays to you, all of you.